I'm Steve Raymond, and along with my co-presenters, Drs. Tarnay and Hoffman, I'd like to welcome you tonight to the, I think the second or third, actually, UCLA CME series on uterine fibroids and treatment options for uterine fibroids. We've done this here in this room a couple times, once last year and once the year before. So before I get started, let me ask you, how many people in the room are OBGYNs themselves? How many people are family physicians or internists? Okay. How many people deal with fibroids on any routine basis? Sort of. Okay. And how do you deal with it? It's somebody who raised their hand. How do you deal with fibroids? What is something you see in your practice, or something you deal with patients in some other way? I see. Okay, great. So hopefully this series of talks will give you an idea of where the landscape is for uterine fibroids in 2011. So we'll just give you an introduction, talk about, actually that's Chris Tarnay, who's going to talk about conventional emerging treatment, and then role of uterine artery embolization, and we'll finish with that and talk about MR-guided focused ultrasound. So this is part of a multidisciplinary effort. It's kind of unique between OBGYN and radiology in terms of offering women kind of a one-stop shop for all uterine fibroid type decision making, because this is a very common problem, and we feel like this partnership benefits everybody, especially the patient. So we have the referring physician or nurse practitioner, the patient. We have some imaging, which is a key component of decision making. Consultation with radiologists, one or more, and an obstetrician gynecologist. We have some metrics as part of the fibroid evaluation. We use a standardized questionnaire to sort of quantify everybody's symptoms. Then we can sort of give them one of many options, and including high-intensity focused ultrasound, embolization, various surgical therapies, hormonal therapies, and others. And then we obviously refer them back to the referring physician. But often patients come in without a referring physician, they're self-referred. We can also uniquely offer combination therapies, and that we will touch on today as well. And then finally, we have an East-West Medicine Center and several alternative therapies that can sometimes help some women that aren't either candidates for conventional therapy or don't want conventional therapy. So MR imaging, we feel, is one of the keys to our assessment for the different treatment options. It's the best imaging modality for decision making. It provides a reproducible assessment of uterine fibroid size, number, and location, and it helps characterize fibroids, because you can't do that with ultrasound, characterize the cellular content of different fibroids. And that's something new, I think, relatively new concept, because it triages patients sometimes at least to the non-surgical therapies. And then finally, I think it helps distinguish the mimics of fibroids very nicely, like especially adenomyosis. It helps distinguish those entities very nicely. So here's a typical T2-weighted MR, and basically it's a sagittal image. There's a spine. That's the abdomen here, the abdominal musculature, and you see a variety of fibroids here. So not only can tell you that the fibroids are, for example, here submucosal with about a 50% extension. So this would be classified as a type 1 intercavitary fibroid potentially, but you can see there's a deep myometrial extension. So this may not be the ideal candidate for hysteroscopic resection. But on the other hand, there's an intramural fibroid, a subserosal fibroid, and so on. It's very easy to see these fibroids and to characterize them as classical fibroids. Now, we can see different kinds of fibroids. So here are a variety of classical fibroids. This is a hypercellular fibroid. And for non-surgical patients, it responds especially nicely to uterine artery embolization, for example. So we can tell you, based on this decision-making, what we can do. And, really, ultrasound can't give you this kind of information. It'll tell you there is a fibroid. It can't tell you where and what, well, it can't tell you what kind of fibroid it is. On the other hand, we have cases of this misdiagnosed all the time on ultrasound. This is a case of adenomyosis, and not fibroids, diffuse adenomyosis, all these little bright spots throughout the uterus, and the symptoms often mimic those of fibroid-related symptoms. And here's a case with both adenomyosis here and fibroids there. And here's a recent case where on the ultrasound we just said, well, there's a fibroid. It was referred to the clinic. I looked at the MR, the T2-weighted MR. Here's the bladder. Here's the uterus with the fibroid. I kind of looked at the endometrium, it was kind of splayed. So I said, well, why doesn't Mike Johnson or Chris do a saline hysterosonogram? And sure enough, this is an intercavitary fibroid. This woman was bleeding very heavily for the last several months and requiring transfusions and everything else, and wasn't really given too many good options by her primary care physician or whoever she was seeing on the outside. But here is a nice intercavitary fibroid with a neck, which hopefully can be resected hysteroscopically, but can also undergo HIFU if that's what she desires. So with that as an introduction, I think I'll pass it on to Chris Tarnay in just a second. One more thing, one more slide on this. MR is really useful for finding other things that can cause fibroid-like or urethral symptoms. For this woman just underwent surgery for urethral diverticulum, which was diagnosed in addition to fibroids about a year ago. So with that in mind, I think Chris.
All right, well, again, I'll echo Dr. Raymond's sentiments. It's nice to be here tonight. We've got a really nice relationship from the Department of Obstetrics and Gynecology, which I am a member of with our radiologic colleagues. And all this is in an effort to sort of really combine our thoughts, our energies, our modalities to really provide improved care for our patients. I think the common thread, and as practitioners you guys probably also feel this, is that fibroids, a common and really vexing problem, often lead patients with feeling very limited options, and it's always compounded, of course, if they're younger patients desiring fertility. So I thought I'd spend a little bit of time talking about uterine-sparing options and sort of where we are to date in terms of some of the options that we've available to our patients. All right, so, just for everyone's sort of UCLA familiar. So I work in the 200 Medical Plaza building right across the way from Radiology and 100. Our patients will come and often get their imaging done in the morning and come for consultation in the afternoon. And Dr. Raymond and I. Oh, okay, sorry. How's that? Sorry. Maybe I'll just use this mic. Sorry. Anyway, I was just reflecting that for our patients who are under care at the Fibroid Treatment Center, patients will have a visit at UCLA here in the Medical Plaza. They'll be visiting the 100 in the morning and often a consultation with myself or Dr. Johnson in the afternoon, and then we're able to sort of tie everything together generally with Dr. Raymond together, either by a teleconference or in person under one roof. So it really makes a nice one-stop shop for patients where they get their imaging, they get their consultation, and they get all their treatment options, which involve both radiologic, medical, and surgical. Fibroids, as you know, have several different names. They're benign conditions. They have come in a variety of shapes and sizes, and most importantly, location appears to be very important. And we're also now finding out a lot about the gene and the gene phenotypes, that there are probably very different types of fibroids that cause the spectrum of conditions that patients are experiencing. As I mentioned, they're depending on the size, and the nomenclature is still not terribly agreed upon amongst all organizations, but they can be pedunculated, they can be intramural in the wall of the uterus, intracavitary, as Dr. Raymond showed you on MR early, and subserosal or submucosal. And it's these submucosal and intracavitary ones that are the ones that are responsible for the bleeding symptomology that patients are having. And often patients will say, well, I have these big fibroids here, and you've got to go ahead and take all those out because the bleeding is bothering me so much, and they're 49 years of age. Well, it's the ones that are perhaps even small, 1 or 2 centimeters, that are the problematic for bleeding, and taking a large 4 centimeter pedunculated fibroid, for example, out of a 52-year-old will do very little to help that patient and her bleeding condition. So often educating and really talking to patients and using the MR really help target therapy for our patients and can avoid often unnecessary surgery. So just what percent of American women have fibroids? Any guesses? Yeah, so that should be 20%. So that's at a minimum. These are generally symptomatic fibroids. Using ultrasound on young women and menopausal patients, we see a progression from anywhere from 20% in young women to over 70 to even 80% of presence of fibroids viewed by imaging. Okay, we can just base the symptoms in between bulk and bleeding symptoms. Obviously, bleeding symptoms are prolonged or heavy period. Bulk symptoms, enlarged abdomen, abdominal heaviness or fullness. And then you've got the sort of organ dysfunction that can go along with fibroid treatment, urinary frequency, constipation, and infertility. As I mentioned, the incidence we now know seems to increase with age. Whether those patients are symptomatic is still not really well known. There does appear to be a genetic predisposition. We see this more commonly in African Americans, and interestingly enough, African American women appear to be more symptomatic than their age-matched counterparts, for example, who are white. And this probably has to do with the nature and the character and the biology of the fibroid itself. African American women are at 3 times the risk of undergoing a hysterectomy, for example. So there's still a lot to be understood about why fibroids are symptomatic in some women and in others not. All right, so let's get oh yeah, go ahead, Linda. Yeah, it appears to be equally distributed, but that is largely unknown, and that's mainly due to the limitations with population data coming out of Africa. We're basically just at the beginning of understanding the epidemiology of these fibroids here in this country. But it seems like if you look at high-density population areas in Nairobi, for example, studies come out of a very similar prevalence of fibroids. All right, so what are the options? Well, you've got watchful waiting. Once patients are diagnosed, and this is particularly prominent when a patient comes with an ultrasound, they'll have the diagnosis of fibroids. The option of waiting is always a possibility, particularly in the fertility patients who are still desiring fertility. This, however, may not be a viable option for some patients depending on their ethnicity, and there's actually some emerging data that suggests that, again, in certain populations, they can be more symptomatically aggressive. Other options, lifestyle changes, not a lot of data on that, but certainly smoking appears to be related to some symptomology. Medication, generally in the form of oral contraceptives and hormonal therapies. And then we've got the actual interventions. The external-based treatments such as endometrial ablation or uterine fibroid or uterine artery embolization. Then you've got the open surgery, that's the laparotomy, open myomectomy, open hysterectomy. And I want to talk a little bit about minimally invasive options, both laparoscopic, hysteroscopic, and robotic-assisted laparoscopy. Medical management, most effective for perimenopausal patients. In other words, either the patients in their perimenopausal years, medical therapy is generally a short-term option for them, under 5 years. Highly effective for smaller fibroids, Long-term failure rates, however, are high, so the younger the patient, the longer the commitment to the medication, the more likely the dissatisfaction. Myomectomy, as you know, is a common alternative to hysterectomy. It's pretty much the standard of care of removing fibroids for uterine preservation, and the most common option recommended for women who wish to become pregnant. That's changing, however, with some of the emerging data that we're getting, particularly with uterine artery embolization. There's some data suggests that it's acceptable. There's plenty of pregnancies that have occurred after a result of uterine artery embolization. Dr. Hoffman, I know, will talk about that. And now with high-focused ultrasound, there's research ongoing evaluating fertility in these patients. And it appears to be there isn't, for example, and Dr. Raymond will talk about it, we'll talk about placental issues and fertility issues both. So for myomectomies, these are those fibroids that are in the cavity or a large portion of the fibroid extending into the cavity. So depending on the location, patients can undergo hysteroscopic myomectomy. For patients who are still desiring fertility, if this is not combined with an ablation, this is an absolutely acceptable and the preferred method for treatment. It's important to treat these submucous or these fibroids that are in the cavity, abutting the cavity, and probably the best option for patients who are having bleeding disorders due to fibroids who wish to retain their uterus. The size, typically 4 centimeters, is thought to be the upper limit, although that is certainly can be extended to 6 centimeters, for example. It's a quick same-day surgery. Local anesthetic and sedation can be used, although generally use a light general. very good success rates, high fertility rates, and no reports of uterine rupture after myomectomy. So a real nice option for these types of patients. Endometrial ablation. These are for patients only who are done with childbearing. There are a number of different energy sources that we use to sort of destroy the endometrial lining down to the basal layer. It can be done with a loop electrode, it can be done with a coil, it can be done with hot water, thermal ablation, even cryotherapy, and lots of different devices on the market approved by the FDA for the treatment of irregular bleeding. And now with HTA, they're treating fibroids up to 4 centimeters in size. So instead of needing the hysteroscopic resection, which require maybe a little bit more technical work, we can actually insert a device, press a button, it'll thermally ablate the endometrium and destroy the fibroid with very decent results. And this is essentially a very minimal recovery for these patients, very minimal postoperative pain. Endometrial ablation. Then we've got myomectomy. Well, we're certainly familiar with the open myomectomy, a large abdominal incision, either like a C-section incision or even sometimes a midline incision for fibroids that are generally solitary or not too numerous. Laparoscopic myomectomy is really an excellent choice. This can be done with conventional laparoscopy, preserves the uterus, involves the camera and the small ports to perform the surgery, and a good track record in skilled hands. This is an example of a fibroid uterus, multiple subserosal myomas, some as large as 6 centimeters. With a skilled laparoscopist, this can be done as a overnight hospitalization, sub 24-hour stay. Advantages: less pain, less blood loss, less need for transfusion, shorter hospital stay, quicker return to normal activities, quicker return to exercise. All very good retrospective and some prospective data evaluating this, supporting the use of this modality and approach to avoid the laparotomy incision. And now with the advent of robotics, has really helped enable the surgeon to tackle more complex fibroids and to allow more patients to undergo a minimally invasive approach, avoiding the laparotomy. With robotic surgery, we apply this platform to the patient bedside. It's operated under console. These instruments are essentially like laparoscopic instruments with the ability to mimic the human wrist. They articulate in 7 degrees, and with advanced bipolar systems, we can remove the fibroid, do the suturing in a very secure manner, and when compared to traditional laparoscopy and open laparotomy, better patient outcomes in terms of blood loss and even fertility rates and pregnancy. And of course, you got the benefit of the cosmetic effects. So this is a really highly desirable method to help treat patients in a minimally invasive manner. I think I'm going to stop there because I think I've used my 15 minutes and turn this back over to Dr. Raymond. Certainly, if anyone has any questions or about how to refer, Dr. Raymond will give you some options to how to send patients to the Fibroid Treatment Center. Thank you.
Okay, so I just want to quickly review how we evolved into this whole thermal ablation business. It sort of started off with devices like these for the liver and the kidney, where we basically use heat or in this case, to destroy liver tumors or kidney tumors. And we can use heat, we can use cryo to freeze lesions, and this application has also been applied for fibroids percutaneously. But I think, and this was actually tried several years ago and published with these MR-guided cryo systems for fibroids, but that never really took hold, I don't think. It seems like for large fibroids, it wasn't as attractive an option. But it brings us to a technology I think that's very interesting in its promise, because it's a completely non-invasive option for some people for many different applications, including fibroids, which is the only currently FDA-approved option, approved tumor. So basically, this is high-intensity focused ultrasound. It heats tissue non-invasively, and MRI is used for visualization. So the patient lies on an MRI table in the scanner, and the machinery is down there. So it focally heats tissue non-invasively. The only thing the patient gets is an IV and a Foley catheter in the bladder. And besides that, there's no other invasion into the patient, whether it's a needle or anything else. And the nice thing is we can use MR imaging not only to see the anatomy, but to monitor the treatment. There are 3 systems on the market. This system has been approved in the United States since 2004, the Insightec system. This Philips system will be coming online potentially this year. And there's a Chongqing Haifu system in China and the European Union, which is approved there, but not here. These 2 systems are MR guided, and this is ultrasound guided. So these are the 3 principal systems in the world. And basically, but they have the same sort of application. Women lie on the scanner on the table, and excuse me, there's a transducer built into the table which projects the ultrasound energy into a spot in the fibroid and then sequentially destroys them. So the zone of necrosis looks like something like this. Basically, there's a dead zone, there's an admixture of dead and live zone, and then there's a live zone outside. And the nice thing is you can get the signals to convert to these elements into sound energy. These are crystals that convert electrical energy into sound energy, but at therapeutic doses. It's kind of similar to diagnostic ultrasound, but much more powerful. And that's what happens. You can project the sound energy into any depth you wish, up to limits, based on the transducer design. So what happens is, as you get a resonant frequency, the water molecules start to vibrate and heat, and once you get heating in excess of 60 degrees Celsius, the tissue is destroyed, and hopefully for good. And basically, what you end up doing is you have the tissue, you have this water bath, you have the transducer. That's the schematic of the uterus, and there's a water in there. And you have these treatments that are these little ovoid little treatments, and you build up treatment by treatment by treatment. Each of these takes about 20 seconds. And so, you're really limited to smaller volume fibroids. But you can display the thermal energy like this, and the heat is right at the zone where you want it to be. So this is non-lethal. You're only heating in the lethal zone. So you're hopefully safe elsewhere. And you can get up to 4.5 centimeters of treatment per 20 seconds. And you can monitor it with MRI in 2 different planes. It's very nice. So you can heat, and then cool. And you can see it in action with MR without any thermistors or anything like that. And that's what one of these things looks like. Basically, that's a lesion in a fibroid. And you can see the different temperatures in the different zones. So, high temperature in the red zone, low temperature in the zone next to the red zone, and then very low temperatures just outside the zone of treatment. So you can monitor all that. So it looks something like this in a schematic. The woman is on the transducer with the IV sedation, and the transducer basically heats the fibroid kernel by kernel by kernel, and that's how we ablate the entire thing. So, I think it's useful for a certain subset of fibroids that are in the right location and the right size and of the right characterization. So we just kind of build on this whole thing and keep going as we do that. And that's the table. That's more of the table and what it looks like. And I'll just give you another short video of just treatment planning. You just basically you scan the fibroid, you draw a region of treatment. So if this is the entire fibroid, you draw a region of treatment, you plant a bunch of spots, and then it starts sonicating each of those spots. And that's how it works. So it's kind of elegant that way because it's completely non-invasive, and many people appreciate that fact. But again, not for every fibroid. It's very restricted in how we use it. And we can, like I said, as the treatment progresses, you can see the heating exactly where you want it to be, and the red zone is heating in excess of 75 to 80 degrees. And these are the multiple sonications that produce a fibroid volume like this. This is an early case where you had this planned treatment zone, and you see this area that's a big donut hole here of dead tissue. Now, we'll go back and probably get more of it as after this point, but that's how you basically treat and plan with this thing. So currently, we use HIFU for family complete patients, but the FDA has approved it for women who desire fertility. So it's not a complete contraindication. So we have, in our experience, we've done about 50 patients, or 50 treatments, and one woman who had a large fibroid actually has just gotten pregnant. And so, there is no direct contraindication. The fibroid should be non-pedunculated, similar to uterine fibroid embolization. We try not to do submucosal fibroids, although we can do it. We prefer that they be done surgically. We prefer the uterus be anteverted or be anteverted, and we use some signal characteristics on MRI to tell us which are better. The T2 dark fibroids are better. And we try to restrict the fibroid size to under about 9 centimeters. So 5 to 7 is ideal, 9 is the upper limit, and no more than 3 fibroids at the present time. So an ideal patient would be somebody like this with a big fibroid here, close to the abdominal wall, no intervening bowel, and there's the bladder again there. So that's this. In this patient, this fibroid is causing pressure symptoms and urinary frequency because of the compression on the bladder, or in part due to that. Here's a 38-year-old woman with a 9 centimeter fibroid, excessive bleeding and blood clots. You see this fibroid, it pushed up against the endometrium. There are 2 fibroids here. There was both bleeding and pelvic pressure. The treatment was performed, both fibroids were ablated, and at 6 months, significant symptom improvement with about 30% fibroid shrinkage. Here's a 34-year-old woman who's bleeding profusely and anemic, requiring transfusions pretty much monthly. Her symptom score here was 130 before. This was her fibroid. Immediately after therapy, her symptom score dropped dramatically, and the fibroid is completely ablated, and she stopped requiring transfusions almost immediately. And she has since gone on to sort of blog about this whole thing. Here's another woman with bulk symptoms. Her score is 110 before. We got a nice treatment, and both of these fibroids are kind of large, maybe even excess of our own rules. We got the whole thing, and her scores also dramatically dropped after treatment. Here's a 41-year-old with bleeding and bulk symptoms. Her score was 121 before. She had a large hypervascular fibroid here in the posterior corpus of the uterus. Immediately, we had a pretty good result here. The whole thing looked dead, and then 3 months afterwards, her score was cut in half, and the fibroid was completely dead. So this is a significant improvement in bleeding, almost resumed normal periods, and significant improvement in bulk symptoms. Here's a 39-year-old woman with menorrhagia and anemia. Now, this woman had cardiomyopathy. She had no other options. She couldn't undergo anesthesia or anything else. She was bleeding and anemic and had cardiomyopathy with a 25% ejection fraction. So in this case, we treated her, and 3 months post, she looked like this. This was a fibroid here, and 3 months post, the whole thing was dead, and there was part of another fibroid that was ablated, and she almost resumed virtually normal periods after that, and was not anemic. And this was put together by Nellie Tan, our fellow, just looking at a waterfall plot, looking at our entire experience of 50 women or so over 20 months. And if the initial symptom score was about 100, over the 20 months it drops considerably to the 40 to 50 to 60 range. And 40 is considered normal. So, quite a significant improvement in early data. So it's not for everybody, but if you carefully select patients, you can do it. And the early papers, like this one, which only treated part of the fibroid, actually showed good ablative success, but we know that we need to treat the entire fibroid, just like UAE, to do well with it. But even if you treat part of the fibroid, the early papers showed that in 109 patients, the symptom scores and the volume scores were correlated even with partial success. In a 6-month follow-up in this study, 79% of women had a 10% reduction of the UFE survey. Not as good as ours, because they only treated part of it, but but one of the earliest results published. Here's another study from Japan. We looked at 70 women, had 39% reduction of uterine leiomyoma volume at 24 months. So that's pretty good. 30 to 50% is what you about expect. And in this paper by Abby Stewart, there was symptom relief even after only 20% fibroid ablation, significant improvements after 60% fibroid ablation, and only about 6% of people were likely to need alternative therapies after 12 months. So the more you ablate, the more it was correlated with symptom relief. And that's basically what we found as well. The more you ablate, and it makes sense, the more symptom relief there is, if the reason was fibroids to begin with. So currently, actually, this slide is old. More than 6,000 people have been treated around the world, and the symptom severity scores, especially in African Americans, was significantly better at all time points. And let me just conclude by saying that the FDA has allowed this procedure to be done on women considering pregnancy, and this number, which was 41 at the time of the slide, has gone up to almost 100 women who have successfully delivered after this treatment. The majority of people getting this treatment are family complete, but even so, a significant proportion were able to deliver without problems. So with that, I think that's just an introduction to this technology. It's kind of exciting. It's in evolution. There are new machines coming, and and from different vendors, but it is promising in this regard.
Thank you, Stephen. Chris, I'll tell you, this is very fun for me. Stephen said we've done this a few times before, but every time I come, I learn something new from my colleagues. So as things evolve, we're all learning here, which is terrific. Thank you all for coming. You will have paperwork that Rick has asked that you fill out. Right, go ahead.
Thanks. Paperwork inside your folders, please fill this out. It allows us to take care of your CME credits, and it really helps us to get a vibe on what's going on in the community and what we can do to keep putting on events like this. And the second thing I needed to let you know is that all of your parking has been taken care of. So on your way out, when you go to the valet, just tell them you were at the UCLA event, and they will take care of your parking for you.
Thank you, Rick. So I'm going to focus right now on uterine artery embolization. Here's a list of some of the things we're going to cover, so we're going to move very quickly. We're going to start with the ACOG Practice Bulletin. It is out there if you don't have a copy. It looks something like this, and I highly recommend you find it. It's fantastic, and it goes through multiple options, alternatives to hysterectomy in the management of leiomyomas. And you can see on this list is basically the same things that we're talking about today. So uterine artery embolization is what we are going to focus on, and the ACOG Bulletin says, based on long and short-term outcomes, uterine artery embolization is a safe and effective option for appropriately selected women who want to retrain their uteri. So what's the history of uterine artery embolization? Well, it began years ago. Actually, patients wanted to have myomectomies, and the OBGYNs thought it was pretty vascular. So they asked us to start embolizing pre-myomectomy, and indeed patients ended up not needing the myomectomy. So that's essentially how the procedure began. We as interventionalist radiologists have always done embolization, and this was just a new application. So in 1995, 97, and finally in 1999, cases were beginning, and at that time, actually, I even started doing them in the late 90s. Dr. Goodwin was here at UCLA, Mick Lucas is in the community as well, and this is really where it all began. 2002, the FDA cleared embolic agents, particularly trisacral, PVA, and that's what we have been using now for many years. We tend to use trisacral, which is Biosphere product. Data has shown that we get better embolization that way, but throughout the world, a variety of particles are used, and they're used successfully. 25,000 UFE procedures are performed yearly worldwide. Who are our usual candidates? Well, they tend to be premenopausal and perimenopausal women with symptomatic fibroids in this age range, patients who have had their children or do not want to have children, and I'll go through the pregnancy data that I have for you in a little bit. Women want to keep their uterus. They don't want to have surgery. They don't want to be in the hospital for a long period of time. They've had surgery. They've had myomectomies, and fibroids have come back, and their symptoms have come back. And again, it's a big issue for people. They don't want to be in the hospital very long, and they want to return to work very quickly. Pre-procedure evaluation, well, we work as a team, as Dr. Tarnay and Dr. Raymond described. I always am certain that my patients have seen an OBGYN so that we are all on the same page, and most of the time we really agree on what is the best option for patients. Together we assess our physical exam. Is it a bleeding person or is it a bulk person? If it's bulk, it's usually pain or pressure, urinary frequency, pain with intercourse, and back flank or leg pain. We do a physical exam. We make sure they've had a good pap smear. We're always looking at this FSH. Premature menopause can occur with our embolization procedures, and this can be an important variable. We want to know what it is pre-op so we can counsel our patients appropriately. And similarly, we need the basic things. We're injecting contrast. We need to know their kidney function. We need to know if they're going to bleed. So these are the basic lab values that we get. Then, on occasion, if it's a thickened endometrium or that looks like there may be a polyp, we'll do things like endometrial biopsy or saline hysterosonogram. We want to see what's happening in the endometrium. What are the causes of the bleeding? Is it the fibroids or is it something else? And nowadays, we are doing MRI and MRA pre-procedure and post-procedure. Again, I started doing this in the late 90s, and I would use ultrasound pre and ultrasound post, but now MRI is so much better. We see the fibroids specifically. We can see if there's any worry for a malignancy or something that really scares us. It just gives us the whole big picture, which is fantastic. And then 6 months later, for some it's 3 months, I do it at 6 months. Again, I repeat the MRI, and I use gadolinium, and I want to make sure that I've devascularized my fibroids well and that there's nothing worrisome. Again, we correlate with that with the clinical findings, and we're certain that we've had the appropriate embolization. So here's our technique. We enter the common femoral artery and go on into both uterine arteries. Here we come in on the left, then we come in on the right, and we take our catheter to this portion here, and we just prune the tree, we like to call it. Take out those little branches, but we really want to maintain the main uterine artery. We embolize using 500 to 700 micron particles, and then we pre-medicate. Patients will get H2 blockers, they'll get scopolamine patch, Zofran. They do get nauseous, so we're really actively trying to keep that under control. We give pain medication, of course, and I treat with ciprofloxacin and Flagyl. Some people don't, but I have for these years. I really fear the infection, of course, and so I treat aggressively. And then sometimes we need nitroglycerin intraarterially. So here we were initially in the left uterine artery. Now you can see we've taken the catheter into the right uterine artery, and we're embolizing there. So our catheter comes, as I shared with you, to this point here, and we're embolizing the whole uterus. That's something that people think we just go after this fibroid or that fibroid. We don't. We embolize the entire uterus. We get all the fibroids. That's why if there are multiple fibroids, and usually, candidly, they are. Now, on occasion, of course, we have the one dominant fibroid, the one fundal fibroid, but usually there's multiple fibroids, and we treat the whole uterus, and all the fibroids are treated. We have to make sure we get beyond the cervical vaginal branches. There have been cases of vaginal infarction and so forth, so that's one of the things technically we're always looking for. And we talked about the uterine arteries, but on occasion we can have big ovarian arteries, and I'm going to show you an example of that. So we do put our catheter up in the mid-aorta just below the venal arteries, and we look closely to see what kind of other feeding arterial branches we have. And we want to assess, are they feeding the fibroid or are they not? After the procedure, some patients are being done as outpatients. I'm not, most of my colleagues are not, but there are centers that do these procedures as outpatients. I do a 23-hour hospital stay. I feel like I have much more control in that setting. We use PCA pumps, we use Toradol and ibuprofen, really good NSAID baseline. They take it all the time. Again, antibiotics, Zofran. After the procedure, we take out the Foley, we have them ambulating, and I'll share with you some of that data. At 6 hours, we want to prevent the DVT, and if there's any sort of DVT risk, we will treat with some Lovenox. And then we're just want to make sure there's no fever, pain, discharge, and the nausea is under control and patients are doing well. So when they go home, they feel really comfortable with their oral medications that they're going to be okay. The first 24 hours can be a little rough, especially the first 6 to 16 hours, something like that. So again, in our controlled setting, we can take care of all those issues. Discharge, again, oral Toradol and ibuprofen, they take it no matter what. That is not a PRN medication, that's a have-to medication. Antibiotics are the same. Colis and Zofran are PRN. Percocet also is PRN. They are seen back in my clinic at 2 weeks, 3 months, 6 months, and on occasionally a year, but usually after 6 months, if they're clinically doing well, their MRI looks good, at that point I'll discharge them from the clinic. So let's go over some basic cases so you get a good feel for what we do. Here is a sagittal MR, and you can see the large uterus with multiple fibroids. 1, 2, 3, 4, 5. And this is not unusual. And you can see here's the spine. Here's L5, 4, 3. This uterus goes all the way up to about the L3-L4 level. There's compression, as you can see back here on the colon, and here's the little bladder smooshed on the bottom. Here's the axial section, again, looking a little bit like Mickey Mouse. Here's a little more Mickey Mouse. Again, multiple fibroids, and this is not unusual. Just multiple fibroids. Here's the endometrial canal. So we go ahead and we come in as I shared with you through the right femoral artery, and you can see the nice prominent 2 uterine arteries on both sides. Here we have filling of the fibroid, and on the delayed study, again, remember that Mickey Mouse shape? Here it is, 1, 2, and this is all abnormal vasculature related to those fibroids. We go selectively into the left uterine artery and we embolize. We take out all those branches, we prune the tree. Similarly, we come in on the right side and we get rid of all these abnormal uterine artery branches. Again, abnormal vessels. And here we have it at the end. There's no more Mickey Mouse. Everything is nicely devascularized. And even on the delay study, again, here's the uterus, but there's no abnormal vessels in that uterus anymore. Here's another example. This is a little different, that's why I'm showing it to you. Here you see a uterine artery, corkscrew on the left, not much on the right, but look what's coming down from the top. That is a corkscrew from the top, that's going to be an ovarian artery vessel. So hypoplastic right uterine artery with a large, rather dominant right ovarian artery. We have to go ahead and do something to take care of it. Now here we're treating the left uterine, here we're treating the small right uterine, and here is the ovarian. See this? And we will have to treat that because, as you can see, this is supplying blood to this large fibroid. If we do not take this ovarian artery out, this patient will fail. Indeed, we treated and embolized that ovarian artery and the patient did extremely well. No premature menopause. She did fine. And again, here we are in the delayed study. The artery runoff is completed and there is no vascularity to the uterus. So what are our results? How do we do? Well, with patients who are bleeding, I'll keep it simple for you, they improve dramatically about 81 to 100% of the time, simplifying 90% of the time. How about bulk symptoms or longer? Again, 61 to 100% of the time, simplify will keep it 80% of the time. So we do a little better with bleeding than we do with bulk, but they do extremely well. Objectively, which we find extremely important when we're trying to measure these things, we're looking to have a 40 to 70% dominant fibroid volume reduction at 1 year and a 40 to 60% uterine volume reduction at 1 year. Indeed, as I shared with you, I do the MRIs at 6 months, and this is absolutely what we usually see. So it's tremendous shrinkage in the uterus. Today I had a patient, again, she was like that first one I showed you at the L3-4 level, and now her uterus is all the way down and the top of it is at the L5S1 level, just a markedly smaller uterus. So we're technically successful. We can get into those uterine arteries 98 to 100% of the time. On occasion, we have spasm or hypoplastic vessels or distal cervicovaginal branches that prohibit our success, but that's extremely rare. Assuming we're technically successful, if we fail, it's usually due to the fact that there's ovarian artery collaterals that are supplying blood to that fibroid, which we did not embolize, and they persist, and their symptoms persist. The fibroids shrink at 3 months and at 1 year. Again, you can see uterine volume going down, but it continues out to 2 years. So even though I measure it, we measure it at 3 months or 6 months most commonly, and we look for that 40 to 60% overall reduction. They continue to shrink for years. So let's look at some data now. The Fibroid Registry, it was published in January 2008. It's 3-year data. It's a multi-center trial, 3,300 patients initially, and after 3 years, 1,900 were in the registry and 1,200 completed the survey. At 3 years, what did they find? Durable results with uterine artery embolization. There were good outcomes when performed either in an academic setting or by a private practitioner. It was not limited to the academic world, which is terrific. So a lot of interventional radiologists can and should perform this procedure, and they'll do it well. 86% of the patients reported substantial improvements in symptoms and quality of life. There was a 15% rate of reintervention. 10% had a hysterectomy, 3% had a myomectomy, and 2% had a second uterine artery embolization. 90% of those patients treated avoided a hysterectomy. Now, how about UAE versus hysterectomy? There was randomized clinical embolization versus hysterectomy trial performed in the Netherlands, and it was small, but it's one of the primary randomization trials that we refer to frequently, and it was UFE versus hysterectomy. 34 centers. All patients had severe bleeding, they had failed other treatment options, and they were therefore willing to undergo a hysterectomy. That means they had to screen a little bit because the patients had to be willing to be randomized to the hysterectomy limb. 6 weeks after the treatment, the embolization patients were more satisfied than the hysterectomy patients. It was an easier procedure. However, at 2 years, the embolization procedure, patients were 90% satisfied with their procedure, and that was the same as with hysterectomy. So again, the embolization procedure held up to hysterectomy, if you will, but the satisfaction of 90% was the same as in the hysterectomy data. At 2 years, 76.5% of the embolization patients had avoided a hysterectomy, a little less than in the registry data, remember that? And the quality of life and menorrhagia improved in both groups significantly. Both the uterine artery embolization and hysterectomy affected the ovarian reserve if they were over 45 years of age, and I'll share that with you when I go over the complications a little bit. Basically, if you're younger than 45, you have very little chance of premature menopause, and if you're over 45, it goes up dramatically. So the authors determined that embolization is a good alternative to hysterectomy. Now we have 5-year outcomes. This was just published in August of 2010. 93% of those original patients returned their questionnaire. The average age was about 50 now. There were 19 secondary hysterectomies, that's 23.5% in the embolization group in the first 2 years, and another 4 between 2 and 5 years, and those were all because of bleeding complaints. So 28.4% at 5 years. So the success rate avoiding a hysterectomy was 71.6% at 5 years, but 76.5% if it was technically successful. I guess they had a variety of patients where they could not get into both uterine arteries, and so that limited the study. But again, 76.5 is what they have if they were technically successful. So 75.9% were symptom-free or had great to moderate improvement, and 13% were unchanged. Overall conclusion, embolization is a proven valuable treatment alternative for surgery in women, for symptomatic women, for surgery in women with symptomatic uterine fibroids. So basically, embolization held up very well to the hysterectomy, yet there was a group of patients who certainly did need to proceed with their hysterectomy even after the embolization. How about financially? They looked at the same group of patients and they decided that the 24-month cumulative cost of embolization is lower than that of hysterectomy. From an economic perspective, embolization is a superior treatment strategy in women with symptomatic uterine fibroids, and that was considering the MRIs with it. Here's more. Embolization is effective and durable and with few complications. So again, it's held up well relative to hysterectomy, but patients need to know it is not 100% successful, and indeed there's a chance somewhere between 10 to 20% chance at least that they may need reintervention over the following 2 to 5 years. How about versus myomectomy? And this is very interesting data. Again, MARA, 2008, they randomized embolization to myomectomy. It was the first randomized controlled trial. Mean follow-up was 2 years. With embolization, of course, you had a shorter hospital stay and faster recovery. Repeat interventions were a little higher, 6.9% with embolization versus 3% with myomectomy. Symptoms resolved in 87.5% of the embolization patients and 93% of the myomectomy patients. Again, very close. The rate of pregnancy was higher post-myomectomy. Concluded, embolization is less invasive and there were identical clinical success rates versus myomectomy. But myomectomy was superior to embolization regarding reproductive outcome, meaning if you want to get pregnant, consider the myomectomy first. How about Narayan, July 2010? It's the most recent retrospective, long-term data, 5-year study. And this was consistent with the other studies, but this is, again, most recent. Embolization, short hospital stay, fast recovery, repeat intervention. This was less, and this is interesting, 8% for embolization versus 14% for myomectomy. Little shifted there. But embolization patients were more likely to report greater improvement in symptoms and have fewer additional interventions, but myomectomy patients were more likely to try and get pregnant. They did quote this Goldberg study, however, that said that had 53 pregnancies post-embolization and 139 pregnancies post-myomectomy, and the embolization patients had an increased risk for preterm delivery and malpresentation. So let's talk about pregnancy and embolization. Standards of practice, August 2010, a desire to maintain fertility is a relative contraindication to embolization. Myomectomy remains the standard of care for preserving fertility because of the increased risk of spontaneous abortion, preterm delivery, and abnormal placental implantation with embolization. Indeed, when you have fibroids, you have an increased risk for placental abnormalities, placenta previa, and so forth. But when you have an embolization, that risk goes up as well, and you can get the accretas and the percretas where that placenta will literally grow into the uterus, similar to if you've had multiple cesarean sections, for example. So there is a higher risk. The conclusion of this large standards of practice study is embolization should be considered in patients who are not good myomectomy candidates and in patients who refuse surgery. Now let's talk about our complication rates. We talked about the amenorrhea. Again, 45-year-olds, 0 to 3%, very low. And this is lower than we've said over the prior 5 to 10 years, but it is extremely low. In fact, if you're in your 30s, it's really almost minimal. We do get a baseline FSH, and we follow that closely. But if you're over 45, it really jumps up into the 15, 20, and here it says 20 to 40% range. So patients have to understand that that absolutely may happen. Their ovarian reserve is less, and they're the uterine ovarian collaterals that we may embolize even if we don't want to. We may not see them, and we may embolize them. Prolonged vaginal discharge, transcervical leiomyoma expulsion, and I'll go into that a little bit, sepsis, DVT, and non-target embolization, those are all very low. So fibroid registry data that I shared with you, that was that 3,300 patient. They have close to 3,000 that they followed. No deaths, 2 permanent injuries. One was a puncture site and one was bilateral oophorectomy 3 weeks after embolization. 4% readmission, pain, nausea, etc. 1% of readmission for a DNC, fibroid being expelled, which I will show you. And 3 had hysterectomy within 30 days, which is 0.1%. So here's expulsion, and I think, Stephen, when I was asking you that question about the submucosal fibroids, this is what you're talking about. So we in the embolization world have the same fear, if you will, that we do not want to have a fibroid proceed into the endometrial cavity and have to be hysteroscopically removed. But that can happen, and we warn patients it may happen. So submucosal fibroids with an interface dimension ratio of greater than 0.55 are more likely to migrate into the endometrial cavity after embolization. The patients that became symptomatic had a ratio of 0.81 and a max fibroid dimension of 6 to 17 centimeters. Smaller fibroids were able to basically make it through. They were able to pass and not get stuck. So what we do is we calculate the submucosal interface. We measure from here to here and here to here, and we divide that by the maximum fibroid diameter, and that's how we come out with this interface. And if it's a larger fibroid, 6, 7, 8 centimeters, and we have a large interface, we warn patients that this may be a complication they may incur. Here is an example. Again, this patient was warned, and indeed within a couple months, this fibroid had migrated. Can you see it here, going into the endometrial canal? And part of it did need to be removed, but here we are in the post, I don't know how long this was out, maybe 6 months, something like that. The whole fibroid is gone, and all you have is a little scar. So this patient actually did extremely well, but unfortunately she did have to have an intervention and have the OBGYN go in and hysteroscopically remove the dead fibroid. How about sepsis? Well, here's an intracavitary fibroid, and as again was talked about, hysteroscopically you can go in, remove this fibroid, and then do your embolization. If you have an intracavitary fibroid over 4 centimeters, they can infarct and become partially expelled, and we don't want infection to occur. Fibroids in the middle of the uterus, in the submucosal region, they have a better response to embolization and shrink more. Submucosal fibroids decrease the most, average of 71% post-embolization, but subserosal fibroids decrease the least, average of 47%. So those are concrete numbers. We measure them off the MRI, and that's the kind of shrinkage we are looking for. Pedunculated fibroids, we used to be very fearful about the size of the base, if you will, and if the fibroid was greater than 50% of the stalk and the attachment, we were fearful it would fall off, if you will. But here are 3 articles that show that indeed we really don't need to worry very much, that indeed patients have done extremely well with that, and they tend not to fall off. How about DVT? Again, we're much more careful with deep vein thrombosis. We get patients up and walking after 6 hours. We put compression on their legs. And if there's any sign at all that they may have a predisposition towards a clot, we will anticoagulate them. Anatomic variations. Again, I showed you the 2 uterine arteries and the 2 ovarian arteries, but actually we can also have some funky things. I saw this patient today in clinic. And indeed what she has is she has a round ligament artery. And that, with this corkscrew, is providing blood supply to the uterus. And in her, I embolized the left uterine artery and this round ligament artery. At the time, I just thought it was a uterine artery. I later learned that it's a round ligament artery. It's extremely rare. And a small other real uterine artery on the right. She also had a large left ovarian artery and a small right ovarian artery, but I decided to hold off on those. I thought it was way too much. So again, these two small arteries on the right and a normal uterine artery on the left. Embolized her. I saw her back today, 6-month follow-up. We indeed infarcted all her fibroids. That was not an issue, and it was the right decision to leave her ovarian arteries alone. But you know, we're all learning, and I said to her, I'm learning from your case, because her ovarian artery was very large, and I did think about taking it at the time, but I did not, and I'm glad I didn't. So here are some ovarian arteries that you can look at and see what I'm talking about. I showed you one before. Here it is. Again, this is supplying the fibroid. I need to take that out. I really don't have a choice. How about from below? Remember I talked about the uterine artery to ovarian anastomoses, and these are beautiful. Here I'm in a uterine artery, and can you see? Here's the ovarian artery. And this needs to be taken out. This one I can see. Some of them I can't see, and when I can't see them, those are the ones I embolized inadvertently. So here what I did is I came up and I put a couple little coils in here, blocked it off. Without the particle, you're not going to kill anything. There's enough collaterals to keep it alive. And then I was able to embolize the fibroid appropriately. Adenomyosis, Stephen showed beautiful examples. It's where the glands grow into the myometrium and so forth. And the data is not as good as embolization for fibroids, but it's still pretty good. So although adenomyosis may not respond to embolization, a few studies do report durable improvement in 50 to 70% of the patients with adenomyosis alone or coexistent adenomyosis with leiomyoma. And indeed, here you see embolization for adenomyosis. Uterine volume reduction is 25 to 45%. Elimination of bleeding is 50 to 95%. Improvement in pain and pressure is in the same range. Patient satisfaction is very high. It's better for just pure leiomyomas, but frequently you have adenomyosis with leiomyomas. That's very common. And sometimes we can't even tell an adenomyoma from a myoma. It can be very difficult. And this data is even better. So reduction in bulk symptoms, again, 80 to 92%. I told you 80 here in this, again, this is the Quality Improvement Guidelines for Uterine Artery Embolization, JVIR, August 2010. This is even higher. And elimination of abnormal bleeding, again, I said keep it simple, 90%. Remember that? Keep it simple. Bleeding, 90%. Bulk, 80%. Here they have greater than 90%. Bulk symptoms, they rank it at 88 to 92% too. But basically, we do extremely well. Patient satisfaction, 80 to 90%. So summary, conclusion. Embolization is a well-established non-surgical option for the treatment of fibroid patients that have significant bulk and bleeding symptoms. It should be offered as one of many treatment options for patients with these symptomatic fibroids. It's more cost-effective than some of the surgical options, and if patients wish to conceive in the future, myomectomy is preferred, although for non-surgical candidates, embolization can be performed and it remains a viable option. If you have a submucosal fibroid with a high interface dimension ratio greater than 6 centimeters and these intercavitary fibroids larger than 4 centimeters, they have a greater risk of transcervical expulsion, and so we may try and figure something else out or at least warn the patients in advance that that may occur. Submucosal fibroids shrink more than the more peripheral ones, and ambulation compression devices will help to decrease DVT, which may occur weeks after the embolization procedure. Medical prophylaxis, like Lovenox, should be considered in patients with increased risk factors. And that's it.